Good afternoon, everyone. My name is C.B. Mamrell, and on behalf of the Systems for Action National Coordinating Center here at the University of Kentucky, I'd like to welcome everyone to today's Research in Progress webinar on the inter-organizational collaboration in local public health systems. And before I start, I'd like to acknowledge the funding and support of the Robert Wood Johnson Foundation. And I also like to remind everyone that you don't forget that if you have questions about the presentation, to please type them in the chat box at the lower left-hand corner of your screen. So with that, it is my pleasure and privilege to introduce to you our presenters for today, starting with Dr. Justin Marlowe, who is an endowed professor of public finance and civic engagement and associate dean for executive education at the University of Washington Evans School of Public Policy and Governance. Justin has published 3 books and more than 50 articles on a variety of topics in public financial management, including local fiscal policy, financing public health systems, and public-private partnerships. Several foundations and professional associations have supported Justin's work, including the Robert Wood Johnson Foundation, the Bill and Melinda Gates Foundation, and the International City-County Management Association. Justin's regular column in Governing magazine is read by thousands of state and local policymakers, and he is lead author of Governing's popular Guide to Financial Literacy series for state and local elected officials. Our other presenter is Dr. Betty Bekemeier, who is a University of Washington School of Nursing Associate Professor and Director of the Northwest Center for Public Health Practice at the University of Washington School of Public Health. Betty is a nationally recognized public health systems and practice-based researcher focusing on structures and services of state and local health departments in relation to health outcomes and reducing disparities. Much of Betty's research and leadership in advancing public health systems has been conducted with state public health practice-based research networks and the National Network of Public Health PBRNs. She leads several PBRN-related researches, in particular the Public Health Activities and Services Tracking, or FAST, study. FAST is an ongoing multi-state PBRN study to develop the evidence regarding health outcomes associated with variation and change in local public health infrastructure and service delivery. So with that, I'd like to turn it over to you, Justin and Betty.
Well, thank you very much, CB. It's a real pleasure to be here with everyone today, and thank you all for joining. A real pleasure to have an opportunity to tell you about the work that we've been doing on interlocal collaboration, interorganizational collaboration among local health systems, and focus specifically on a couple of the key outcomes that we'll be talking about here today. Before we do much else, I think it's important to give just a quick illustration, kind of take the topic for today and put it in a real tangible setting for everyone. And the best way to do this is to share a quick little story that comes straight out of this particular study. So if you're familiar with for part of our study, we were able to go and talk to folks in eastern Oregon, in particular Umatilla County, and then Morrow County. Umatilla County is highlighted there in green. This is up in the northeast corner of Oregon. And Morrow County, their neighbor just to the west. And this is a very good example of the kind of interlocal collaboration that we're talking about here. If you're familiar with this part of the country at all, each year they have what they call the Pendleton Roundup, which is a huge rodeo that in effect doubles the population of the county for a couple days. And bringing all those folks, most of them coming from around the region, creates lots of opportunities, but it also, as you can imagine, creates some public health concerns, particularly around things like norovirus, spike in STIs, lots of the kinds of things that happen when you get that many people together, particularly from within the region. So in response to this, these two counties and their public health staffs have managed to put together a variety of interlocal sharing agreements, in particular one where they agree to share staff to trade cases back and forth as necessary in the immediate aftermath of the roundup. So after if you see a case of active TB, if you see a spike in STIs, whatever it might be, they're able to quickly communicate, quickly share staff, share resources, whatever they need to do to manage to address those problems in real time. These are two rural counties leveraging their resources through cross-jurisdictional sharing, a very good example of the kinds of things that we studied in this particular study. So to give you a sense of what we did and what we'll be reporting on today, again, we're looking largely at the question of whether cross-jurisdictional sharing affects the cost, quality, and the reach of local public health services. As we'll hear in a second, there have been lots of different work that's been done to understand sharing itself, the mechanics of how it works, how different local public health jurisdictions work together in both formal and informal ways. And there's been quite a bit of work on the motivations. Why is it that local health jurisdictions decide to share resources? We're focused here more on the outcomes. So we want to understand what motivates local health jurisdictions to do this, but then we also want to see if it actually has the intended effects. And our hypothesis going into this was that it would, that there's plenty of reasons why sharing through leveraging resources, expanding the geographic reach of a particular service delivery area, lots of reasons to think that this would in fact produce better services, produce the same services for less spending than for local health jurisdictions that aren't involved in this kind of sharing. We found that was largely the case, that in fact there's not a ton of evidence according to our initial findings that local health jurisdictions are saving an enormous amount of money by entering into sharing agreements, but there is evidence that jurisdictions that do this are more efficient, and some initial evidence that jurisdictions that do this have slightly better reach in certain service areas in particular, and we're continuing to develop that part of the study. We did this by looking at a variety of different kinds of data, largely in 4 states, New York, Oregon, Washington, and Wisconsin. We combined some survey data that we collected with a variety of different administrative data, both on spending and other financial data, as well as service delivery outcomes. So it brings together lots of different information to try to get at this basic question of how and when does sharing matter. We were able to do this, of course, through the generous support of lots of different partners. The Robert Wood Johnson Foundation, in particular through the directive program run by this center, was the funder for this project. And here at the University of Washington, we had lots of good folks working on it. My colleague and co-author, Betty Bekemeier, who will be talking here in a little bit, as well as a great staff here. We also had wonderful partners in 4 different states, and one of the interesting things about the study was that we brought together lots of different kinds of folks, some state-level folks, some local-level folks, some university folks, and they all deserve our thanks here at the outset. Certainly the New York State Department of Health, Chris Malin and his team, the Oregon Coalition of Local Health Officials, Kathleen Johnson and Morgan Cowling, the Wisconsin State Department of Health, and our contact for them is Jennifer Tibaldi. I'm sorry, the Washington State Department of Health. Our contact there is Jennifer Tibaldi, and then in Wisconsin, we had good access through our colleagues at the School of Nursing at the University of Wisconsin, Teresa Watson, Susan Zahner. So just to give you a sense of what's happening in the world of cross-jurisdictional sharing, this is certainly a hot topic. We're hearing more and more every day, it seems, about interlocal collaboration, intermunicipal cooperation, what is sometimes called functional consolidation, that is to say the sharing and the combining of services without an actual without formally merging political entities like local health jurisdictions. And this is growing in popularity. There's obviously immense fiscal pressure on local governments these days, and lots of pressure to do more with less, or in some cases to do less with less. And so by having mechanisms to share resources, combine resources, we're able to continue to deliver services or maybe blunt the effects of the kinds of serious fiscal stress that a lot of local and state governments have experienced over the last several years. There's been some empirical work in the public health space on this, a small empirical literature that looks at consolidation, that is to say actually combining different local health jurisdictions. It finds that there is some evidence of some efficiency gains, both by combining individual jurisdictions and then also doing regionalizing of services. But what we don't know, and our focus for our motivation for going into this study, was whether you get the same kinds of benefits from cross-jurisdictional sharing. So keeping the original political boundaries of these entities, but engaging in the kinds of sharing of resources that we're describing here without having to actually consolidate politically or functionally. And this is a big question in public management and public administration in general. Very limited evidence on the actual outcomes of this style of collaboration. So an important topic and one that we were happy to look at. So to talk a little bit about how we arrived at where we arrived, to be clear, we were working from a very specific definition of cross-jurisdictional sharing. There's lots of different definitions of the concept out there. we were looking specifically at sharing of resources between two local health departments. Again, going back to the Umatilla, Morrow County example I was giving there. Two jurisdictions sharing actual resources, in that case staff time, but there are plenty of different types of cross-jurisdictional sharing that involve sharing facilities, sharing equipment, sharing money, any kind of resource sharing between two local health departments. And it's important to contrast this against the different kinds of sharing that we see out there. There are certainly regional collaboratives where there's lots of information and advice shared. There's lots of different kinds of regional sorts of services where there might be resources that are paid to the state government or to a regional entity. Those are all very important, but that's different than the kind of sharing we're looking at here, which is really one local health jurisdiction to another. So to understand the landscape of this sharing, we administered a survey, which I'll talk more a bit about here in a second, to all of the local health jurisdictions in those 4 states, New York, Oregon, Wisconsin, and Washington State. And we were able to get a response rate to that survey of about 65% for a total of 143 local health jurisdictions who participated. This is a thorough survey. I know several of you on the call were kind enough to fill it out for us, and it gathered a lot of different kinds of information about why jurisdictions are sharing, their perceptions about whether it's working, and lots of the kind of backstory behind the different kinds of sharing that are currently happening. We found that sharing is everywhere. About 70% of the local health jurisdictions who we were in contact with said that they're doing some kind of sharing. And one of the really key findings to come out of this whole study was that a lot of that sharing is very recent. About 28% say that they're sharing now more than in the past 12 months. And as you'll see here in a second, a lot of the sharing that is now happening really came about since the Great Recession, really within the last 3 or 4 years. So this chart shows just the extent of sharing, where it's happening in different kinds of service areas, and then what kinds of local health jurisdictions are doing sharing. We found that 2 main takeaways here, that the majority of sharing is among small local health jurisdictions. So that's defined here as local health jurisdictions that are serving populations of less than 50,000 people. And some, you could take that up perhaps to population less than 250,000 people as well. If you look at those 2 segments of our population, you see that that's where the majority of sharing is happening. It's also, in terms of functional areas, happening more commonly in areas like emergency preparedness, which makes a lot of sense. If you have a need for a rapid response to an emergency, a homeland security concern, a flood, a natural disaster, all of those emergency preparedness, particularly in rural, large counties, it helps to have sharing arrangements so that one jurisdiction can deploy resources faster and closer to the action if it happens to be at the border with another county or another local health jurisdiction. So emergency preparedness is one of the big areas where we see a lot of this. And then we go right down the line in areas like environmental health, maternal-child health, and communicable disease, which is a big focus area for us in this study. We found that there's a lot of sharing happening in this kind of catch-all other category. A lot of that we found as we got out into the field and started to talk to local health jurisdiction personnel. A lot of that is in areas like opioid programming and opioid prevention. A lot of these sort of new services and new demands for services that have come up in the last couple of years, for which there were either no resources or limited resources, were natural candidates for sharing for a lot of jurisdictions, again, in the aftermath of the Great Recession. So a lot of sharing, a lot of it happening in some select areas, and particularly among smaller and more rural local health jurisdictions. We have lots of questions about the underlying motivations for sharing. So why are jurisdictions choosing to do this in the first place? And we found this interesting kind of break in the survey. So what you see in this chart is a list of motivations along the left side, things like provide better services, make better use of resources, respond to program requirements. And that whole, we asked essentially to check all that apply. So identify any of the following motivations that led you to engage in any kind of a sharing arrangement. And we see this sort of clean break when you look at provide better services, make better use of resources, and respond to program requirements. In all 3 of those cases, more than half of the jurisdictions that identified sharing in given areas said that they were sharing for those reasons. And each of the different service areas are identified with a different shape there. So communicable disease is the circle, emergency preparedness is the triangle, and so forth. And so we find that regardless of the service area, provide better service, make better use of resources, and to a lesser degree respond to program requirements are the main motivations for this. We were a little bit surprised when you look down that list and you see things like save money, for example, as an area where certainly that's a motivation, but it's not nearly as popular a motivation as some of these others. And so we take from this that the goal of a lot of this type of cross-jurisdictional sharing is really to provide better services, make better use of resources, do more with less, make sure that we're maximizing and in some cases leveraging our capacity, as opposed to doing it for the explicit purpose of saving money. So from there we wanted to get more into the actual outcomes. So again, does cross-jurisdictional sharing save money? And does it have an impact on things like quality and reach of services? So for the first part on cost savings, we focused in on a particular subsample of our data here. This was looking specifically at Washington State. In Washington State, we're fortunate that we have good data on spending and revenue for local government, for local health jurisdictions. And it's far from perfect, but it's some of the better data available when you're studying things like the unit costs or the per capita costs of delivering different kinds of services. So for this specific focus on cost savings, we zeroed in on the jurisdictions in Washington State that had responded to our survey and said that they were engaged in sharing. We were able to go out and get all of their data on spending in lots of different functional areas within public health. So what we have here is an opportunity to focus specifically in on this question of efficiency and cost savings. So to do this, we had to, it's obviously very tricky to kind of do this before and after sort of comparison. So we engaged in a technique that we call propensity score matching. Propensity score matching is really just a technique that allows you to take different jurisdictions that might not otherwise be comparable and compare them along a specific dimension. So in this case, we wanted to take the few jurisdictions that are engaged in different styles of sharing and compare them to the most comparable jurisdictions we could find that are not doing any kind of sharing. So taking those that are engaged in sharing and trying to find a match or a comparison group for each of them. So we did this through a technique called nearest neighbor matching, which I'm happy to talk more about in detail if anyone's curious, where we were able to, for each of the jurisdictions that said that they're doing sharing in given areas, we matched them to 4 other jurisdictions that are not sharing, and we match them according to a couple key criteria, things like population, local poverty rate, and then some of the other service delivery outcome indicators, so the way that their effectiveness or the extent to which they were delivering the same types of services to the same types of populations. And so we did this for a variety of different service areas to come up with comparisons. And so this chart here really summarizes the results of that overall exercise. So what we have here is along the bottom, each of the different service areas where we were able to look at. And for each of these, we computed at the jurisdiction level a per capita spending measure. So we have the per capita spending on childhood immunizations for 25 different local health jurisdictions. Some of them that are sharing and some of them that are not sharing. The solid line and the circle identifying the mean for that group. The solid line shows us the local health jurisdictions that have cross-jurisdictional sharing in that area, and the dashed line shows us those jurisdictions that do not. And so for child immunizations, for example, we see that the jurisdictions with cross-jurisdictional sharing were spending about $2.35 per capita to deliver those services. The same type of services delivered by the same type of jurisdictions on average were spending a little bit closer to $2.55 to $2.60 per capita, $2.55, $2.60 per capita. Now that is not necessarily a statistically significant relationship there. That's not a statistically significant difference. And we see that same basic pattern across each of the different types of jurisdictions that we identify here. No clear evidence that sharing results in significantly less spending per capita compared to jurisdictions that are not doing sharing. So on this one, again, not surprising given that save money was not necessarily a main motivation for a lot of sharing. We found that there was not necessarily a financial relationship here as well. So we also, at the same time, wanted to dig into this question of efficiency. Obviously, one of the big motivations was make better use of resources or make more effective use of resources. So we decided to do a sort of a separate analysis, a specific analysis around efficiency using a technique known as data envelopment analysis, and which again I'm happy to talk some more about as well. And with data envelopment analysis, what you're doing is essentially looking at how efficiently or how effectively an entity translates its inputs into its outputs. In other words, taking all of these inputs like population, spending, poverty, all of the underlying characteristics of a jurisdiction, how efficient is it in translating all of that into its intended outputs? In this case, again, things like child immunizations, water system inspections, these kinds of outcome indicators in the key communicable disease and environmental public health areas that we're looking at here. So what we wanted to know was, after doing this, are the most efficient local health jurisdictions also the ones who are engaged in sharing? And the key takeaway from that part of the analysis was that, in fact, they are. Local health jurisdictions that are engaged in cross-jurisdictional sharing do tend to be more what we call technically efficient, or efficient according to this specific definition of efficiency. And in short, what you see here is a ranking of different local health jurisdictions according to these technical efficiency scores. And so in this case, local health jurisdiction number 33, which was tied for number 1, technically number 2, but tied for number 1 as the most efficient jurisdiction in our sample on communicable disease services, also happened to be one that is engaged in cross-jurisdictional sharing, as was the case for the same jurisdictions ranked number 4 and number 5. And so in this case, we found that, at least on communicable disease, jurisdictions that are sharing do tend to be toward the top ranked in terms of efficiency. Not necessarily the case on the environmental health side. In fact, we found that a few of the jurisdictions on the environmental health side that are among the least efficient are also the ones that are sharing. So there's a variety of reasons we can potentially explore for that. But at least on the communicable disease side, we find that technical efficiency and sharing tend to go hand in hand. So the final piece that we wanted to deal with then was the question of how is it that jurisdictions see the effectiveness of these outcomes. It's one thing to talk about efficiency and cost savings, but does cross-jurisdictional sharing actually accomplish what it's intended to accomplish? Does it make services better? Does it help deliver services that couldn't otherwise be delivered? In our survey, which again was patterned after some existing work that had been done in this space in areas like in Wisconsin in particular, our findings were pretty consistent with what had been shown there before, which was that sharing does in fact help local health jurisdictions to deliver services they couldn't otherwise deliver, or give them capacity that they couldn't otherwise have. Overwhelmingly, respondents to our survey said that that was an important motivation, and in fact cross-jurisdictional sharing allowed them to do that. At the same time, there's not a tendency toward formal evaluation. So most of the cross-jurisdictional sharing arrangements that we saw did not have a formal evaluation component or a formal performance benchmark built into them. It was mostly whether or not the grant was renewed or whether the contract was renewed was the kind of main performance indicator. So that, all the more reason to study directly the question of, do these sharing arrangements accomplish what they intend to accomplish? So to do this, we did something very similar to what we did with our cost savings analysis. I did a match sample, went through this time through all of our states. Fortunately, we had these outcome data from lots of different jurisdictions across all 4 of our states. And we were able to do the same matching process and go through and compare the outcomes for a specific set of areas, in this case service delivery reach, for a variety of jurisdictions across all 4 of those different states. And so here we find a quick summary of those outcomes. Again, same basic area. We're looking this time at child immunization completeness, food service inspection reach, and water system inspection reach. So these are all reach measures. Percentages here on the left are, just as it would suggest, the percentage of immunization completeness, the percentage completion around food service inspections, the percentage of residents who who are served by a water system that has not had any violations recently, And the takeaway from here is that we do see some significantly better reach for jurisdictions that are doing sharing compared to those that are not. On something like childhood immunization completeness, we get a completeness rate just shy of 70% for the jurisdictions that are sharing, and we get a completion rate closer to 55% for jurisdictions that are not sharing. Again, to the extent that these are similar kinds of jurisdictions according to our matching process, this is definitely some initial evidence that sharing does produce better reach around childhood immunization. Similar sort of pattern, not quite as strong on food service inspections. Here about a 7 or 8% difference between the reach for those that are sharing compared to those who are not. And again, consistent with what we saw earlier, not necessarily the same effect on water system inspections. There was not necessarily a huge difference. The length of the lines here tell us the high and the low. So there were several jurisdictions for the non-sharing where you had quite low rates, and that certainly had some impact on these overall statistics. But again, the takeaway, some very early initial evidence that we've been exploring here suggests that we do see some outcomes that would suggest that you do get better reach when you do cross-jurisdictional sharing. So lots of work yet to do on this. We've had, again, some initial evidence that making better use of resources and being more efficient are key motivations. Saving money is not necessarily the main reason why a lot of jurisdictions do this, and that certainly has implications for a lot of the public policy debates surrounding cross-jurisdictional sharing. A lot of state legislators, local public health commissioners and others think that sharing and consolidation is a great way to save money, and that may or may not be the case based on the evidence that we found through all of this work. Also, again, some indication that cross-jurisdictional sharing improves reach, but not necessarily evidence that it ends up showing us not necessarily seeing lower spending. That's also, again, not a huge surprise given the underlying motivations here. So we still have some work to do. We need to draw a sharper distinction between make better use of resources and saving money. Obviously, there's parts of that are kind of intertwined, and as we continue to work through the data analysis, we're seeing where save money ends and where better resources begins. And we've also done some field work to better understand exactly how and why it is that sharing might make better use of resources, or why sharing might improve the reach of services. And so we've been doing some of that work. We'll continue to do some of that qualitative analysis to understand exactly how and why we see the service delivery effects that we see. So that's the main part of the presentation, and I want to give my co-author, Betty Bekemeier, a chance to offer any closing thoughts here before we turn it over.
Hi, everybody. Can you hear me?
We can. Thank you.
Great. Thanks, Justin. That was fabulous, and Justin really is the lead, the primary investigator on this study. So, but it's been fabulous to work together. I want to just add a couple of quick things. There is particular focus on communicable disease in this study, not just because it ended up being showing particular leverage in terms of better resources and better services, but also we, for this study in particular, we pulled together data from these 4 states that were involved around, although I don't think all our analysis around the CD control outcomes included all 4 states, maybe 3 of the 4, I can't remember. But anyway, but my point is we particularly pulled together service-related data around CD control specifically to be able to look at some specific outcomes and look at how does this impact efficiencies or outcomes in a specific area, in this case, CD control. And Justin, you clarify that a little bit if I'm not saying that correctly, but nonetheless, it was particularly interesting in looking at the efficiency scores, et cetera, that communicable disease stood out on its own. And I don't know, Justin, you can also speak to that that necessarily means that the others were really not as efficient, but to me, the overall study itself suggests that there definitely are seemingly better services, better efficiencies that can be gained through certain services. And we need to know a lot more about exactly how that happens, what they are, and more research will support this. Also, as we get feedback from those on the line who are listening, as well as Gianfranco, I'd really like to hear. I know that for those of us that are practice-based researchers, we're working with those in practice, and we hear it all the time, that cross-jurisdictional sharing is a big issue. People are really looking at this in terms of creating efficiencies and getting more, maximizing their very limited capacity, unfortunately limited capacity in communities. So I'd really like to hear from folks as to what to do with these findings and how to make them most useful to practice and in terms of their dissemination, implementation, and practice and policy. So, tee up some of your thoughts about that, and I'll hand it back to you, Justin, and then our Gianfranco.
Yeah, thanks, Betty. Great comments all around, and your characterization of that part of the study is absolutely correct. Again, if that wasn't clear, for the analysis of the reach measures, we were able to go and get data from all 4 states on that. That wasn't a subsample analysis like it was with the others. Great. Thanks for clarifying that.
All right. Thank you, Justin. Thank you, Betty, for that wonderful presentation and the fantastic research work that you guys are doing. And so before I turn it over to our commentator, I'd like to introduce our commentator for today, and he is Dr. Gianfranco Pezzino, who is co-director of the Center for Sharing Public Health Services at the Kansas Health Institute, or KHI for short. Gianfranco is also the Senior Fellow and Strategy Team Leader and oversees KHSI's work on public health services and systems. His work focuses on the development and dissemination of best practices for the organization, financing, and delivery of public health services, which supports local public health departments in their preparation for national accreditation. The Center for Sharing Public Health Services is a multi-year, multi-million-dollar national initiative funded by the Robert Wood Johnson Foundation and focuses on cross-jurisdictional sharing as a strategy to create efficiencies in public health. Dr. Pezzino has international health experience and has served as state epidemiologist and medical director for the bioterrorism program with the Kansas Department of Health and Environment. And during this time, Gianfranco is also president of the Council of State and Territorial Epidemiologists. And in addition to his work at KHI, Gianfranco serves as the Shawnee County Kansas Health Officer and is a site visitor for the Public Health Accreditation Board. So with that, I'd like to turn it over to you, Gianfranco, for your comments.
Thank you very much. And first of all, let me congratulate the project team for a very insightful research project. I think you're really doing a very good job at framing a lot of the issues that we need to explore and for which we still have perhaps more questions than we have answers. But just the work of framing the issue is in and of itself a very positive contribution, I think, to our understanding of what cross-jurisdictional sharing can do for public health. And I totally agree with your starting point, which was, I'm paraphrasing, of course, but when many people think about cross-jurisdictional sharing, the mind goes immediately to taking 2 or more health agencies and merging them into one. Now, that consolidation model is definitely one that is available and is occurring in many cases, but it's by all means not the only model for sharing resources. And I think we need to do really more work in trying to understand what the different models are and how they differ in what motivates the partners to engage into each model, and what the impact may be under certain circumstances of one model versus another. For example, things like the number of health departments, does that affect, the number of health departments involved in a sharing agreement, does that have an effect? Is there a kind of point of maximum return after which, if you keep adding agencies, you may create a bigger bureaucracy and a convoluted mechanism that actually will not produce ideal results? Does the size of the health departments, does the size of the populations involved in that sharing effort matter? So still a lot of questions open that we need to address, and I think studies like this really help in going in that direction. I want to talk a little bit about the motivation and then the impact of the sharing agreements. And I'm not surprised that you found that cost saving was not at the top of the list. It was not mentioned very often or as often as other initial motivators for the people that answer your survey. And my sense, based on my experience with the center in the last several years, is that the motivation is really different depending on who you ask the question. And if you ask the question to public health officials who were the target of your survey, your findings really don't surprise me. That their motivations tend to be more in terms of improving effectiveness of the services and maybe enhancing some of the services, but their immediate thinking is not around the cost. The story usually is different if you start asking the same question to policymakers. And that's a very broad term by which I mean entities like members of boards of health, for example, county commissioners, or members of the governance bodies that will actually have a big role in both approving the sharing agreements, but perhaps more important in shaping the budget and the scope of activities for the local health agencies. And so in the mind of those policymakers, in my experience, cost becomes much more important, and sometimes it's actually the driving force. And it's in many cases it's actually cost. It's not really efficiency, and I think that's an important distinction that, again, I think we need to probably do a better job at framing this issue. If people walk into a cross-jurisdictional sharing agreement with the idea of saving money as a main motivation, the probability of success is not very high. CJS may save money under certain circumstances, but it's more likely that CJS may do something like improving efficiency or improving the effectiveness of the services. And I think the results of your data speak to that effect. But they may or may not translate into a reduction of the absolute cost, the absolute expenses that the agencies involved are putting out. And that's an important distinction because in our experience, again, the most successful projects are those that reach a good balance between improving efficiency and improving effectiveness for the services involved in the sharing agreement. And so efficiency is really defined here in a very simple way as getting the best and the most out of the investment that you make into the system. And so the investment itself may not reduce in volume, but what you get out of it is actually more. And the effectiveness is actually the impact in terms of quality and intensity of the services that you are delivering. Another concept that we have tried to introduce in this discussion is the concept of return on investment, which I find personally very intriguing, but we haven't really been able yet to put our arms completely around the concept, and some of you may be more familiar than I am about that, but essentially what that means is let's not focus on how much money we're spending, but more on does this help the agency achieve its mission and its goals better than if we didn't have it. In this case, this being the cross-jurisdictional sharing agreement. So I think it would be very helpful to work with our policymakers to help them frame the issue, not so much in terms of we need to cut and save money, but more in terms of what can we get out of this money, and does this investment and does this sharing agreement move us more towards achieving our goals as an agency. I think your analysis also shows the complexity of doing a financial analysis of spending, and I'm not going to go into the details because many people on the phone today probably are much more fluent than I am in that field. But it's really hard to capture the cost of the services and then the changing costs when those services are delivered independently by independent agencies as opposed to jointly through a cross-jurisdictional sharing agreement. And then even when you look at the cost, just using per capita expenses, for example, while it certainly has its own advantages, including simplicity, also has its own limitations. If you don't compare that per capita, or if you don't balance that per capita expenses with the intensity and the quality of the services that are provided. So it only tells part of the story, but nevertheless, it's one of the few tools that we have to measure to do a spending analysis. Couple of final words on how we measure the impact of these agreements, and it's interesting and not surprising again for me, having had many conversations with folks in the field that are engaged in these efforts. It's interesting that most of them will tell you, yeah, this works, this is great, we are providing better services. Some of them will even tell you we're saving money, and some of them will not. But most of the time, the impression is favorable. We have a lot of anecdotal evidence in that direction. What we are really lacking is harder data that we can use to actually show and measure the impact of these agreements. That's one of the areas in which our center is currently working. We are funding 4 demonstration projects or pilot projects that are actually aimed at measuring the impact of their implementation of CJS in some areas in which they have CJS agreements in place. Those are 4 projects, so again, they are not going to give us the breadth and depth that we would like to have to say policymaker, if you enter into this sharing agreement, this is the change that you can expect in both cost and effectiveness of your services. But what we hope at least is to show that kind of measurement of the impact can be done, and maybe to pave the road for some methodology to be deployed on a more widespread scale, through which then we can actually understand better how these agreements affect the delivery of public health services at the local level.
Thank you, Gianfranco, for that excellent commentary. Before we go to the questions, I would like to turn it back first to you, Justin and Betty, if you want to take us some time just to respond to some of Gianfranco's comments or add on to it.
Yeah, a couple things to say real quick, and Betty might too. Thank you, Gianfranco, as always, for all of your insights on this and for your support of this project all along. We really appreciate that. The one thing I would say is just to emphatically agree with the point that you made about how complex and how difficult it is to do this work, particularly on the cost-saving side or on the spending side. Absolutely, a measure like per capita spending only begins to speak to the resources that it takes to deliver these services. Several of us have been involved in lots of work on the costing of public health services, and it's obviously way more complex than just looking at a number like per capita expenses. So we're very aware of that, and in describing this work and in writing it up for publication, we've been real straightforward with that limitation, and really do look forward to the work that I know some others are doing on that question specifically, how to better think about measures of the financial resources that go into delivering these services. And on a point about return on investment, and I think there's a couple sort of questions from the audience along these same lines. One of the things that we were able to do was to as much as the data will allow, kind of build that into the analysis. So as part of our comparison, as part of our matching process, on the spending side in particular, we took jurisdictions that were doing essentially the same thing, serving the same type of population and delivering services at the same level of effectiveness. So we matched jurisdictions by those that were performing at about the same level with respect to these indicators like child immunization completeness, water system inspection reach, those kinds of things. Essentially saying, again, back to that return on investment question, if you're willing to to have the same underlying output, or the same underlying population that you're serving, and you're getting the same basic output related to that population, let's compare what kinds of money needs to be spent to deliver those same basic services. And if you can get to the same outcome from the same population for less money, then that's a decent insight into this question of cost savings. And so we've tried to do that, and there's obviously some real limitations on that. And we look forward to hearing more about that, because I know there's others who are doing some really great work in that space. So thanks as always, and we'll continue to try to build in a lot of those insights into the work that we're doing here. I don't know if Betty had anything else to add to that before we move back over.
Yeah, just that, Gianfranco, I love that you sort of point out the difficulties and the value of getting at the impact, the return on investment and the impact piece. I mean, that was part of our working really hard to pull in some data, comparable data around communicable disease control, so we could really get at that. And it's a very elusive, difficult thing to do, but that is really a tribute to the business of doing this through practice-based research partnerships and us being able to get at that kind of thing, which is really great. And also your point about using this study as a way to shape kind of policy discussions around efficiencies and greater, broader, wider impact versus this cost savings discussion, et cetera, among policymakers. But I don't want to take up time anymore, so I'm going to hand it over to you, CB, so we can hear from our audience.
All right. Thank you, Betty. Thank you, Justin. Thank you, Gianfranco. So as I go through these questions, feel free, all three of you can chime in. And I do apologize for the audience if we can't get to your question, but we'll be sure that if your question was not given, we will forward these to Justin and Betty. So since we left it over at ROI, there's a question from Deborah. How do you explain ROI to policymakers when, from their perspective, the investment is local, but the return might not specifically be local? Is there a better way to explain return to the non-public health community? And she also adds, can any of the ROI discussions include what is actually saved rather than spent? So that is what happens when a bad public health event doesn't happen. So how do you sort of measure that? So do any of you guys want to answer that? So I don't know if you can see that in your chat box too, in the questions section.
Sure, it's a great question, and in some ways it's really at the heart of what we're trying to do here. You're right. I mean, you pointed out exactly the challenge. So much of the value add of public health is stuff that is invisible and stuff and avoiding bigger problems. And so how do you quantify that, or how do you tell that story in a compelling kind of a way? There's certainly a whole world of people who do benefit cost analysis and that type of work, which is kind of related to, but really quite different from what we did in this particular study. And I know that there's been some attempts to try to do that, to speak directly to that sort of that those kinds of returns, if the returns are in terms of avoiding problems or money saved by not having a problem. But in terms of specific insights into how best to explain it, I think I might turn to Gianfranco, who I know is having those kinds of conversations all the time.
Yeah, I think it's a very good question, a very important point for policymakers, and I can tell you that even the most open-minded local policymakers will struggle with the question of what to do, how to balance something that can benefit the public good as opposed to being strictly accountable to their constituents. What I mean by that is simply put, most policymakers will find it hard to justify an investment of local tax dollars that benefits people outside of their jurisdiction. And so it's extremely important that every sharing agreement that is proposed and discussed with policymakers be a balanced agreement where everybody has something to win, everybody meaning every jurisdiction participating part that needs to be communicated and clearly explained to the different policymakers from the different jurisdictions involved. Simply reasoning in terms of broad avoidance of disease in our region, for example, it may or may not be very effective. There has to be something more concrete that the agreement can produce for each of the jurisdictions that are participating, and that then needs to be explained to the policymakers of that jurisdiction.
All right. So Joe has a question. I think he was referring to either this slide or this slide. He asked, are those just counts, or are they adjusted by the number of LHJs for each type? So I guess it would be this one. I'm not sure. And he also asked a follow-up. Yeah, so he also asked a follow-up question, why adjust for service effectiveness? In the spending analysis, might effectiveness be an impact of sharing? Aren't you potentially adjusting away some effects? So, yep, go ahead.
Yeah, good question. So on the first one, these are just counts. So this is just the number of sharing arrangements, just the raw count of the number of sharing arrangements. So we didn't adjust that at all in terms of the incidence or the percentage of jurisdictions that have an arrangement in that area. These are just straight counts. Again, there's 143 of them, so you can kind of do the math and see the rough incidence that would tell you that about a third, for example, of the respondents have a sharing arrangement in the area of emergency preparedness, and then it kind of goes down from there. And in the areas like some of these business competencies, areas like purchasing, HR, financial management, it's a real small number. And so we, rather than convert them into percentages, thought it made sense to just sort of share the overall count of each of them. So the second question about the relationship between effectiveness and sharing. You're correct. I mean, there is certainly the potential that by just looking at jurisdictions that are comparably effective, that are getting the job done in basically the same way or at basically the same degree of effectiveness, that you might be understating or washing out some of the relationship between sharing and effectiveness, or even between spending that's required to build capacity to be more effective. So you're definitely right. We're kind of assuming that all jurisdictions at a given point in time are basically the same. That's just a limitation of the study that we have to live with. In a perfect world, you would have data over time, right? You'd be able to look at exactly that dynamic by taking the points at which investments were made and the points at which sharing arrangements were developed and then brought online, and you could maybe get at that question with a little bit more precision than we're able to get at with just one slice of data at one particular point in time.
So we have a question from Jared. I'm not surprised that emergency response is the most common area of CJS. Federal and state level policy has been pushing this approach. Communicable disease alternative is more often left up to the states and locals to decide how this service is delivered. Did you control for federal and state policies driving CJS versus CJS arrangements that are left up to local decision makers?
Yeah, another good question. We did and we didn't. We did in the sense that all of the comparisons that I'm talking about are within a state. So you're looking at where the matching process is matching jurisdictions in Washington State to other jurisdictions in Washington State, for example. So as much as those state-level policies have an impact, and as much as those state-level policies affect all local health jurisdictions the same, then that's built into this analysis. And we can argue about whether state policies affect all local health jurisdictions the same, but at an aggregate level, that's what we do have. It's a really good question about kind of building in or controlling for the extent of federal control versus state and local control of a service. We're looking, again, all of our analysis looks at each service area separately. So we're looking at child immunization completeness separate from food service inspection reach, separate from all other services. So in as much as that question of federal versus state and local control is kind of contained within each of those service areas, then we are able to control for it at least a little bit. But you're right, even within that, from one state to the next, you see huge variations in the extent to which there is real local control or real state control over a given service area. So we're not able to maybe control for that as effectively as we might like. But again, as much as state level policy matters, that is more or less built into the analysis.
I think we got time for some more. Yeah, go ahead, Betty. Yeah.
I was just
go ahead,
going to
Betty.
briefly say, I was just briefly going to say that it was a little bit validating for us that did come out, that emergency preparedness did come out by far as the biggest, because that is what you would expect given that history.
Yeah. So we've time for two more. Okay. Thank you, Betty. We've got time for two more questions. One's from Mary with the communicable disease services. What were the services that were reviewed related to CJS, EPI versus direct client contact? I think, Betty, you would be able to answer this too.
What were the, say that
yeah,
again, what were the services?
That were reviewed as they related to cross-jurisdictional sharing. Was it EPI versus direct client contact? I'm not particularly sure how this question was, but I guess it relates to the outcomes. I'm not sure. Do you see it on your chat? If not, we can take the last question then. It's a little more generalized.
Okay.
Yeah, we'll just do. Yeah. So the question from Patrick is: do you see potential utilization or growth for these types of collaborative CJS across larger, possibly non-geographical adjacent communities in order to continue or expand services in the face of potential federal support being withdrawn due to the priorities of the incoming administration? So I guess this question is for all three of you.
Yeah, I can make a quick point on that. The answer is yes. In a lot of our, again, we defined, the way that we define cross-jurisdictional sharing here almost by necessity meant that we were talking about adjacent public health agencies. When you're talking about like a shared facility, for example, that's shared just by two local health jurisdictions, or a shared staff member, or a shared information technology system or procurement system, those kinds of things. Inevitably, you're talking about jurisdictions that are geographically proximate, because the whole goal is to expand the geographic reach or to scale up the geography that a service area can cover. At the same time, we have found through our qualitative work in this space a lot of interest in exactly the kinds of sharing that the question alludes here, that the question alludes to here, like in areas like, for example, information sharing, the ability to quickly disseminate information from one jurisdiction to the next about an active TB case, for example, or those kinds of things where you have the geographic proximity may not necessarily be really central to the goal of the sharing. And so if you're willing to think about resources a little bit differently than we thought about it in the study, if you think about sharing information or sharing expertise broadly as a resource, then there's definitely a lot of that kind of interest. We've talked to plenty of folks, particularly in rural areas, where the response to things like the opioid epidemic is something that really demands, when you have a population that tends to move around a lot, tends to be in different geographies at different points in time, you really need to be willing to share resources with people other than your neighbors, simply because that's the nature of the population that you're serving. And so we saw plenty of examples of that sort of thing. Again, it fell a little bit outside the scope of what we studied here, but I wouldn't be surprised if we see more of exactly that kind of activity in the future.
Betty, would you like to add anything more?
I would definitely I would agree with Justin about the importance of this. Also, that I think it also points to further research that's needed. Folks are really, I know, very, very attentive to the whole issue of improving accountability and maximizing what they can do and quality and use of their resources, et cetera. But we also at some point need to understand when is too much of that, when is that stretching resources too far? And Gianfranco kind of alluded to that too, because nor do we want to put ourselves in the position, our systems in the position of having policymakers expect too much of them, et cetera. So that's, I think, an important point that needs further investigation in the future.
Excellent. Well, thank you so much, Dr. Justin Marlowe and Dr. Betty Bekemeier, for the wonderful presentation. And like we said, that this presentation is available on our website. It's recorded and available for download, and you can also get in touch directly with Betty and Justin. We'd also like to thank you so much, Dr. Gianfranco Pezzino, for your time also as a commentator today in our webinar, and we'd like to thank all of you who joined us today and also asked questions. And we'd also like to remind you of the upcoming webinars, so you just check on those two as well. So with that, thank you again to our presenters and our audience, and we hope to see you soon again. Have a great day. Thank you so much.